Your vision is continuing to get worse. Your glasses aren't helping, and you're not sure why. Have you talked to your eye care professional about keratoconus? In this episode of OCuTALK, Optometrist Matthew Kauffman tells us all about keratoconus, the diagnostic process, and the treatment options available. Dr. Kauffman?
I want to talk to you.
Not now, later.
No, now.
Hello, everyone, and welcome to OCuTALK. Today, we're going to be talking with Dr. Matthew Kauffman, an optometrist with Contemporary Eye Care in Katy, Texas. Dr. Kauffman, how are you?
I'm doing well. Thank you so much, Thomas, for having me on the show today.
Well, it's always good to have a fellow Katy Texan with us. So today, Doctor, we're going to be talking about keratoconus, which is a fun word to say, but also a very interesting topic. But first, I'd like to start by just getting a little introduction to you, sort of your background, your specialty, and what you do every day.
Sure. So I'll start by kind of picking up from optometry school. So I graduated across town at the University of Houston College of Optometry, and then I went on to complete a residency in cornea and contact lens in St. Louis, Missouri. After St. Louis, I came back to Houston. I worked in a private practice part-time fitting specialty contact lenses on folks with keratoconus, cornea transplants, other irregular cornea type conditions. But I also taught part-time third and fourth year students in the cornea and contact lens clinic at the University of Houston. Some years later, I joined UHCO kind of as a full-time assistant professor, and then became director of the cornea and contact lens clinic, teaching third and fourth year students, and then also kind of as a clinical investigator for a wavefront guided scleral lens research study, where we kind of measured higher order aberrations in patients with keratoconus and other similar corneal conditions, and determined if they were a good candidate for wavefront guided scleral lenses. And then here most recently, kind of in the fall of 2022, I decided to leave the university and open up my own private clinic here in the Katy, Texas area, where I focus on fitting specialty contact lenses, caring for individuals with keratoconus, as well as kind of routine eye care needs as well.
That is a very broad background, Doctor. So, in that discussion, I heard you mention our topic numerous times, keratoconus, right? And as I said, it's a fun word to say, but what in the world is keratoconus?
Yeah, that's a great question, Thomas. So keratoconus is a progressive bilateral asymmetric disease of the cornea. So the cornea is the very front part of the eye. It's characterized by a steepening or a distortion, apical thinning, as well as corneal ectasia. Ectasia just means kind of a thinning of the tissue. Now, keratoconus was once thought to be unilateral, but we now kind of have figured out that unilateral keratoconus does not exist. Oftentimes, patients with keratoconus, they have keratoconus in both eyes, but they have one eye that's more severe or one eye that's more advanced compared to the other eye. So I was going to say it was once thought that the prevalence of keratoconus was about 1 in 2,000, and that's kind of based off an old study looking at patients at the Mayo Clinic. But now new research has indicated that the prevalence is as large as 1 in 375. So that newer study was kind of utilizing updated technology, updated diagnostic instruments. So now we kind of realize that keratoconus is a little more prevalent than what we once thought.
So how does this differ? So we're specifically talking about abnormalities on the cornea itself. How does this differ from other let's call them shape-related disorders of the eye, when you're talking about maybe like an astigmatism or something like that? How is this shaping different than that type of shaping?
Sure. So with keratoconus, we have kind of a thinning of the tissue. And then when that corneal tissue becomes more thin, it's not as rigid or stiff, and so it kind of bulges forward there. So whereas astigmatism, that causes light to focus at two different points, And so we need, glasses or soft contact lenses to correct that astigmatism. Usually with keratoconus, there's one focal point where that cornea is a lot more steep compared to the surrounding tissue there.
Okay, but what is it that causes this? Is this a genetic thing or is this an environmental thing? What causes keratoconus?
And that's a really great question that I don't have an exact answer to. But we do know that with keratoconus, it's kind of a combination of metabolic, chemical changes. You had mentioned genetics as well. So genetics are definitely thought to play a role in this condition. Research has shown that there's multiple genes associated with keratoconus, and I think current research shows between about 6 and 16% of patients with keratoconus have some history of familial disease. So definitely when I interact with patients with keratoconus, I kind of ask about, any other family members that have a history of keratoconus, or even if that patient has kids, have the kids been screened or tested for keratoconus, yet?
Well, that's a good. I'm glad you brought that up. Let's talk about that, right? How does one find out that they have keratoconus, right? What are the symptoms that would lead to a diagnosis?
So I think the biggest symptom of keratoconus is a patient might experience vision that just cannot be corrected over time. So they go to the eye doctor or optometrist or ophthalmologist, they get their vision measured. And when they go to fill their prescription, they're just like, hey, I can't really see with my current glasses. They go back, maybe the prescription has changed a little bit. Maybe 6 months later, their vision continues to change. From a eye care practitioner side of things, they're oftentimes their nearsightedness or myopia keeps getting worse and worse as time goes on. And then you had mentioned astigmatism before. So patients with keratoconus oftentimes have higher elevated levels of astigmatism. And so we know by measuring their prescription, that can also increase over time as well.
So let's imagine this is what I'm experiencing, right? So I'm a patient. I've had a lot of trouble, right? I keep having to get different prescriptions all the time. My eyes are changing a lot. I can't get fitted into contacts. What would be my next step, right? Like, how would a physician such as yourself screen for keratoconus? What does that experience look like?
Sure. So I mentioned some improvements in technology and diagnostic equipment that help us detect keratoconus. So two types of equipment specifically is a corneal topography and a corneal tomography. Now there is a slight difference between the two in that a corneal topography kind of focuses more on the very anterior or very front surface of the cornea. So it kind of shows us the sections that are more steep, sections that are more flat, and then also kind of gives us what we call an elevation map where it kind of tells us the high points as well as the low points. Now, most recently, a corneal tomography. So this is kind of using a camera and a slit source of light to kind of take a scan of the whole entire cornea. So we're not just looking at the front surface anymore, but we're also looking at the middle of the cornea as well as the back surface of the cornea. So what's great about this type of equipment is we're able to determine the thickness of the cornea. So before, we would have one little probe that kind of measured corneal thickness, and we'd have to kind of take a guess as where the thinnest point of the cornea might be. But now with this corneal tomography technology, we're able to gather thickness data across the whole entire cornea to identify the thinnest portion as well. Now, the other nice thing about a corneal tomography is oftentimes keratoconus will start on the posterior side of the cornea or the back surface. And so we might see changes associated with that before they start to notice any changes with their vision, or we detect any changes on the front surface of the eye. So I think the biggest change in how we kind of treat and manage keratoconus is we're able to detect keratoconus at a sooner or earlier age. And our number one goal is to kind of preserve the visual acuity or preserve the visual quality that patient currently has before it changes or gets worse.
I'm glad you brought that up too, because especially in eye care, right? Like there are sometimes varying procedures or protocols that would be done based on age, right? Like, younger eyes are still developing. There's things going on. Is there an age limit to keratoconus? Does this affect all ages, or is this something that happens later in life? How does that work? And then specifically, I want to know, based on what you were just saying about early detection, right? Is this a thing where if I got in really early, that there are things we can do, or does that not matter?
So with keratoconus, we used to think that it would start in kind of our teens or our 20s and progress or change to our 30s or our 40s. Most recently, a study by Jennifer Harthen and her research group kind of looked at approximately 200 school-age kids that ranged from 3 to 18. And so they brought a corneal tomography device to the school and kind of took images on all these kids to classify, did these kids have keratoconus? Were they suspicious of having keratoconus? And so what they found was that they had 6 of those 2,000 students with a definitive diagnosis of keratoconus. And they had 3 of those students that were kind of classified as being suspicious or suspect for keratoconus. And so that kind of put the average age of children with keratoconus about 13 to 14 years of age. And so we're actually, again, with this new improved diagnostic equipment, we're kind of discovering keratoconus at a little bit earlier age than once we originally thought. So I definitely think that's kind of changing the philosophy on how all of us practice, and to get these corneal tomography instruments into more practices and more clinics so that we can screen all these children to kind of rule out keratoconus.
So let's talk about that. Let's say I had a diagnosis for keratoconus. What does that mean for me as an eye care patient, right? What can be done, or how does it affect my overall visual acuity?
So keratoconus is different for every individual, and oftentimes it's different between the two eyes. So most of my patients with keratoconus, they'll have one eye that's kind of more advanced or more severe. So we can kind of think of the treatment options broken down in 2 different categories. So one is kind of an optical category, and then the second is kind of a surgical category. So if we look at the optical category, regular glasses or soft contact lenses. So those might be ideal for patients who are very early in the keratoconus process or very mild. But for patients with more moderate to more severe keratoconus, the visual acuity achieved with glasses or soft contact lenses will not be, acceptable or adequate there. We also have other types of contact lenses, and I know you've highlighted these types of lenses in your other OCuTALK series. We have hybrid lenses. So hybrid lenses are a combination of a soft lens around the periphery and then a gas permeable or a GP lens in the center. We have gas permeable lenses, we have scleral lenses, and we also have wavefront guided scleral lenses. So the main advantage of kind of a rigid or a gas permeable lens is it kind of creates a nice smooth surface so that whenever light enters the eye, it gets focused at one single point versus being scattered with either glasses or a soft contact lens. So I would say the majority of my patients are kind of at least at a moderate to severe level. So we have fit most of those patients with a gas permeable lens or even a scleral lens to kind of achieve the best vision possible. Now, I also mentioned surgical options. So April of 2016 is when the FDA approved a procedure called corneal cross-linking. And so what corneal cross-linking does is we apply a drop called riboflavin. We kind of set the patient to look at an ultraviolet light for anywhere from 10 to 20, 30 minutes. And then during that process, the cornea kind of develops additional what we call cross links or bonds between the different fibers. So the main purpose of corneal cross-linking is to kind of slow down or stop the cornea from getting more and more steep and getting more and more thin as time goes on. So it essentially kind of freezes the cornea at its current spot. And so with the diagnostic instruments to kind of make an early detection or an early diagnosis, we can now complement that with corneal cross-linking to try to slow down or stop the vision from getting worse. Now, in some patients where the vision has gotten so severe to where even with a scleral lens, they can't function, we also have what's called a cornea transplant. And that's where we kind of take out the tissue that's currently there and then put in a donor tissue. And then oftentimes the advantage with that donor tissue is there's less scar tissue that's formed or developed, and the curvature is a little more flat. So oftentimes we're able to achieve a more sharp and more clear quality of vision.
So is keratoconus a progressive disease? What happens if it's untreated?
So with keratoconus, it's very hard to predict who's going to progress and who's not. Usually the earlier keratoconus is diagnosed or detected, the more likely that individual is to kind of progress, as opposed to someone that's been diagnosed, maybe in their 20s or maybe in their 30s, kind of later in life, they're less likely to kind of progress.
Very good, doctor. Thank you so much about this. Now, let me ask you, is there anything we haven't covered about keratoconus today? We talked about the diagnostic, the importance of early diagnosis. We talked about the different treatment options, right? That there are optical treatments, there are surgical options in more progressed situations. Is there anything that the general public should know about keratoconus other than that?
So one of the things we didn't really touch on is what an individual with keratoconus, how they might kind of perceive the world. So, if you notice any kind of diplopia, so diplopia just kind of means like a doubling type effect. Not necessarily double vision where you see two images here and here, but let's say you are looking at a letter, you might notice some shadows, you might notice some ghosting, you might notice like some smudging or some smearing. Parts of the letter or word might kind of even be missing. I've had numerous patients where, especially at nighttime, they look at like a street light or they look at a tail light, and instead of seeing one single tail light, they might see three little tail lights, kind of scattered or smeared. I had one individual where they kind of noticed, three tail lights kind of in a triangular shape. So those all could be symptomatic of potential keratoconus or some other condition associated with the cornea. So, I encourage those patients to, have their eyes examined. It can be a frustrating process because a lot of times, patients are told, oh, everything looks good. You just require a glasses prescription. But I encourage, clinicians as well as patients to not only start paying attention to the quantity of their vision. So, do they see 20/20 on the letter chart? Do they see 20/30, 20/40? But also pay attention to the quality of the vision. So, a patient might see 20/20, but, how do the letters look? Are they nice, clear, and crisp? Or do they have any of those shadows or ghosting associated with that? So I think by asking those types of questions, during our introductory case history, we can try to, get to the bottom line of what's really causing the patient, to have problems with their vision.
Thank you so much for being with us. Is there anything else you'd like to share before we go?
No, I think we've covered it. And again, I appreciate the invitation.
Absolutely. Well, thank you so much for being with us.